Good morning. Thank you for participating in California EMSA's first annual Stroke Summit. My name is Nicole Bosson. I'm an emergency physician and the Assistant Medical Director at the Los Angeles County EMS Agency. Today, I'm going to be discussing stroke routing for EMS systems. I have no disclosures. So let's start with a patient case. And I want you to consider, in your ideal system, assuming transport times are reasonable, to what type of facility would you want this patient transported?
We're called to a street corner where we have a 57-year-old female found sitting in a car. She was at the store. She was driving her car down the road. Said she wasn't feeling good, and she pulled to the side of the road, and the stopper by stopped by to see if she was okay, and the patient was unable to communicate with her. When we get on scene, the patient is having a hard time communicating with us. They're kind of aphasic and has right-sided facial droop and right-sided weakness. She has no medical problems, doesn't take any medications. At this time, we did do a 12 lead. Came back AFib with a non-STEMI. The vitals are 160 over 90, pulse of 70, respiratory rate 20, setting 99 on room air, blood sugar of 130. She is a little bit diaphoretic, but no trauma, anything like that, but she does have right-sided drift.
Do you have a LAMS score for her?
This patient's Los Angeles motor score is reported as 4, and LAMS of 4 or 5 is associated with a large vessel occlusion. So we know that endovascular therapy is beneficial for patients with anterior circulation proximal large vessel occlusions, and that faster perfusion results in better outcomes. We also know that delays are bad, that every 1 hour delay results in 5% reduction in the odds of functional independence. As clinicians, we're used to focusing on the patient in front of us. How do we maximize the chances of the best outcome for that patient? In EMS, our focus must be on the system to maximize the chances of the best outcome in all patients served by that system. So there are two general approaches to EMS stroke routing. The first is often called the drip and ship model. In this model, a patient experiences stroke symptoms, and hopefully they contact 911 and activate the system. EMS arrives and transports them to the closest facility, typically a primary stroke center, where they'll receive their imaging and IV TPA if indicated. And then, if the patient has suspected large vessel occlusion, EMS will be recontacted to transport the patient to the comprehensive stroke center where they can receive their thrombectomy. And that time at the primary stroke center is often referred to as door in, door out, or DIDO. In the alternate model, or the mothership model, the patient is transported directly by EMS to the comprehensive stroke center, where they will get their imaging and IV TPA if indicated, and then thrombectomy at that center. So which is best? Well, proponents of the drip and ship model will argue that it expedites care, that you should get the patient to the closest facility that's able to administer thrombolysis to reduce the time to thrombolytics and increase their chances of resulting in reperfusion. They also argue that the longer transport time could result in some patients arriving outside of the thrombolytic window. And in addition, that you can avoid unnecessary long transports for patients who do not ultimately have a large vessel occlusion. Currently, our stroke severity scales in the field are not that excellent, with accuracy somewhere around 70%. So there will be patients transported to the comprehensive stroke center, bypassing a closer facility, that ultimately do not benefit from that therapy. So it's kind of like finding Waldo amongst all the stripes. How do we find the patient who's truly going to benefit from that longer transport time? If you're trying to find Waldo, he's right there. So on the other side, proponents of direct transport discuss optimizing reperfusion, and that reperfusion rates with TPA alone are low for patients with large vessel occlusion, somewhere 8 to 35%, depending on the source. And in addition, interfacility transfers cause delays to endovascular therapy, reducing the effectiveness of this therapy. And so getting the patient directly to the center that can perform this is to optimize the patient's chances for reperfusion. And finally, they argue that volume increases efficiency, that if you go to the comprehensive stroke center, if more patients are treated at these centers, they will become more efficient and reduce the time to intervention, which can ultimately offset the longer transport times. So the best data we probably have on this currently is from the RACECAT trial, which is a multi-center randomized trial conducted in the Catalan region of Spain. And they looked at routing to a center capable of thrombectomy called an EBT center versus the closest primary center based on the race scale. And not surprisingly, they found that IVTPA was more frequent and faster to administration with the PSC routing, and that thrombectomy was more frequent and faster with EBT routing. But ultimately, there was no difference in neurologic function at 90 days between the two groups. So for the primary patient-centered outcome, there was no difference between the two routing models in this high-performing system. So what was our experience in LA? In 2018 in Los Angeles, we moved from a single-tiered stroke routing system to a two-tiered model for patients with possible stroke with last known well within 24 hours and a Los Angeles motor score of greater or equal to 4. The patient was routed to the closest CSC or TSC within 30-minute transport time. Patients with a LAMS of less than or equal to 3 were taken to the closest center. We chose to include CSCs and TSCs at a single tier because our primary goal was to get patients with large vessel occlusion ischemic strokes to the thrombectomy center as quickly as possible. So at the start of 2016, Los Angeles had 4 comprehensive stroke centers, and 40% of the Los Angeles population could reach a comprehensive stroke center within 30 minutes. After the two-tiered model was implemented, we had a total of 19 comprehensive or thrombectomy capable centers, and 93% of the Los Angeles population was able to reach one of these centers within 30 minutes. In terms of outcomes, we actually found that TPA administration increased from roughly 24 to 27%, and thrombectomy rates went up a lot. They more than doubled from 7% to 15%. And this was across all last known well time intervals. So it was not just due to changes in practice. And finally, interfacility transfers for higher level of care went down. In terms of time intervals, first medical contact to TPA was actually reduced slightly, and we did not find any difference in time to thrombectomy. Now, a big concern was that there would be a high rate of bypass of primary stroke centers, and the reality was that we did not find that to be the case. In Los Angeles, the rate of bypass of the closest center has been 7 to 8% for the past 2 years. I also want to mention the time window for routing. In June of 2018, shortly after the transition to the two-tiered system, we increased the routing for patients with suspected stroke from 6 hours from last known well time to 24 hours from last known well time, based on several studies that showed benefit to thrombectomy up to 24 hours. To evaluate this change, we looked at the number and proportion of patients receiving thrombectomy according to their last known well times. And in a cohort of just over 1,300 patients with acute stroke transported to the thrombectomy capable or comprehensive center, the overall rate of thrombectomy was 27%. And while the number of patients decreased substantially as the time interval increased, still, the proportion of patients that were routed who received thrombectomy was quite high, with 14% of patients in the 16 to 24-hour window receiving thrombectomy. So we felt that this really supported the routing of up to 24 hours for patients with suspected stroke. So what does this mean for your system? For the patient right in front of you with the large vessel occlusion, the choice is clear. We need to get them to thrombectomy as quickly as possible. But for system optimization, there are a lot of moving parts. First, you have to consider the availability and distance to stroke centers in your system. You also have to consider your door to needle times, your door in, door out times, and your door to thrombectomy times, because this can change to which center the routing is optimal. There's also the impact of other things like mobile stroke units and aeromedical transport that can really shape how your system will look. Although this is very complex, the American Heart Association, along with numerous partners, recently released a consensus document, which is a great resource for stroke systems. And Dr. Schwalm will discuss this in his presentation next. So in summary, minimizing time to reperfusion improves outcomes. There's no one answer for all systems. Knowing your capabilities of the hospitals in your system and the key time intervals will determine the best routing approach for your system. And of course, EMS is a key partner in stroke care. Thank you very much.